All right, good evening and welcome to our September program of ACAP Cape Fear. Tonight our program is on age-related health and medical conditions. And my name is Dorothy Griffin. I have the honor of leading the leadership team for ACAP Cape Fear. We brought it to Wilmington, North Carolina 1 year ago. So September was our very first program. So we're celebrating 1 year of being here. And I just really appreciate all my team that has been a great part of bringing on fabulous speakers like the one you're going to hear from tonight, and bringing on sponsors and just all the things that go into having an evening like this. For those of you that aren't familiar, ACAP is a nonprofit that started in the Hickory area over 10 years ago, and we have chapters in North Carolina, Pennsylvania, and Georgia. And we're actually bringing several of them on this year. So it's a growing organization, and the whole goal is to really connect children of aging parents with resources, and also give them the support of meeting together with others that are going through the same thing to help you know that you are not alone in this journey. While it's geared towards children of aging parents, the information is obviously helpful for dealing with your own aging or the aging of a spouse or another family member as well. And so our goal is to help educate people even before you need the resources. So one of the best things you can do after tonight is over is to share the information with other people you know, especially those who may be in the midst of caregiving and not able to get out to programs like this. So what to expect, you're going to hear from our sponsor this evening, and then you're going to hear from our speaker. We'll have a time of question and answers, but I think Dr. Rudick is also okay with questions along the way. So as you have them, just feel free to raise your hand and ask those questions, because if you're thinking it, somebody else might be also. And then we typically try to end by 7:30, just to give you an idea. If you haven't helped yourself to sandwiches in the back, feel free to get those. And if you need to use a restroom, they're down this hallway. You'll go past kind of what looks like the main desk, go to the left of that desk, and the restrooms will be on your right. So all of our programs are free and open to the public because of sponsors that help to support us. And our sponsor that's going to share with you tonight is actually one of our core sponsors, which means they provide ongoing support throughout the year and for a number of years. So we're going to welcome Jesse Bassett from Wilmington Funeral and Cremation.
Hey, y'all. I'm Jesse. Can y'all hear me all right? I never know how close to stand to these things. I usually do this without a microphone and not just have at it. But I am the pre-planning director for Wilmington Funeral and Cremation, which means a couple of things. It's an honor to be here and be part of this. I've never been invited to this party before. So my counterpart back there, Chelsea, is the actual member here. She's our outreach director. So she is the neck that turns the head and tells me where to stand up and do my little song and dance. But this will be a very abbreviated version. It also means I have the easiest job in funeral service. While I am a licensed funeral director, all I do all day long is meet with families, most of who are children of aging parents, and get those affairs settled, typically years ahead of time, so that when the day comes, it's all done, it's decided, it's paid for, it's a phone call, and we handle the rest. And that's my job. Now, my job is not to get people to select little boxes and urns and stationery and all that. My job is to help the children of aging parents remove the emotional, financial, and legal burdens of a death, because it comes to us all. And if you've ever had to make those arrangements, you know it is generally an unpleasant experience. So my job is to help remove those burdens, and I love it, and it keeps me coming to work every day. And I get to come to things like this where y'all have sandwiches, but I don't want to talk any longer, but thank you for having us, because I really want to hear what Dr. Rudick has to say, because she is instrumental in our line of work, as you can imagine. Your signature comes through our desks so many times that listen, if I had $1 for every time I'd heard Dr. Rudick's name, I would not have come to work today. So I want to hear from the legend. So I'm going to step down. Thank you all.
Well, I'll give the rest of the introduction for Dr. Rudick. Dr. Mary Rudick is a geriatric physician here in Wilmington, North Carolina. She's on staff at Novant, New Hanover Regional Medical Center as a medical director of the senior care unit. And she also serves as a medical director of several other nursing homes in our area, nursing facilities. And her private practice is called Senior Health Center, and it has been in Wilmington since 1997. So please join me in welcoming Dr. Rudick.
And as they said, I don't mind you asking questions as we go along, and then we can have a question period after as well. So my topic today is what you don't know can definitely hurt you. So we'll talk about prevalent age-related health conditions that we all can get as we get older. One of the interesting statistics is that the number of people over the age of 85 is projected to triple by the year of 2050. 2020, 1 out of 6 people are over the age of 65. So we're living longer, but are we preparing to live better? Are we looking at what we should be doing so that those golden years are going to be healthy for us? And I love this from Mickey Mantle. If I'd known I'd live this long, I would have taken better care of myself. So part of tonight is to talk about how do we take better care of ourselves? And it's never too late. I had a patient in yesterday, 75 years old, hadn't seen a doctor a long time. And, he was expecting me to start berating him and yelling at him. I said, no. I said, I'm not going to do that. I said, you're here. And that's the best thing that you can do is to be here today because it's never too late. So let's just get started. So when we look at common conditions, and these are the ones that I chose because they're silent. And they can be silent, and these are the ones that can cause you trouble as you get older if you don't go visit your doctor. So blood pressure, high cholesterol, coronary artery disease, diabetes, chronic kidney disease, congestive heart failure, depression, dementia, and COPD, which is chronic obstructive pulmonary disease. The big ones are hypertension at 58% and high cholesterol at around 47%. Coronary artery disease, 29%, diabetes, 27%. So when we look at the medical conditions that we should screen for, these are the big ones. And then we'll get into a little bit more with the osteoporosis and all of them. So osteoporosis is one that we all have to be screened for, women and men. Hypertension, high cholesterol, thyroid disease, cognitive impairment, dementia, hearing loss, skin lesions. And we'll go into that in more detail as we progress through the talk. So let's look at osteoporosis. On my right, you can see the osteoporotic bone. It's very honeycomb. There's not a lot of matrix in there. And the problem with osteoporosis is you may not know you have it until you fall and you break a hip. Or you fall and you break your wrist. And then the whole process begins that you do have osteoporosis. And if you would have known about it before, you could definitely have done something about it. So about 1 in 5 women over the age of 50 have osteoporosis. 1 in 20 men have it. Their bone mass is just a little bit stronger than ours. But when you look at the women over the age of 50, when do we start screening for it? And we'll get into that a little bit later, but screening usually starts over the age of 65. But between the ages of 50 and 64, you can be screened if you've had a fracture or if one of your parents have had a fracture, because that's an indication that you may have had osteoporosis. We form the majority of our bone mass by about the age of 20, 25, so thin is not in. And what we're finding now is that the kids that we're bringing up now are sitting in front of the TV or the computer. They're not getting out. They're not exercising. They want to be extremely thin. And all of that's going to add up to a generation of osteoporotic people. That's kind of what my prediction is. And we'll get into what we can do about osteoporosis a little bit later. Hypertension. Oh, not working. What happened? Oh, wait, hold on. Now we got to go back. The back part's not working. Where's our tech guy? Or tech woman?
Tech woman. Maybe the mouse.
Yeah, it should be. Oh, there it went. I
Okay.
think it's like trying to aim it at that little guy.
At that little guy? Okay. So with hypertension, let's talk about that and hyperlipidemia. They're silent diseases. So they can cause arterial disease, which can lead to a heart attack or a stroke. I have seen that happen so many times. Go to the emergency room, Someone's there, they never knew they had high blood pressure, and they come in with a stroke or they come in with a bleed in their brain because of the stroke. So easy to get your blood pressure checked. I think they still do it at CVS and some of the other places. Hyperlipidemia, high cholesterol, and triglycerides are a leading cause as well for hypertension and for coronary artery disease. When you look at the statistics, 58% of people with high blood pressure are over the age of 65, 47% have high cholesterol. Do you know what the first symptom of coronary artery disease is? And this is not to scare you, but it's sudden death. That will be your first symptom of coronary artery disease. And that's really frightening to me. So those are the reasons. I don't think this is working very well. I'm aiming my mouse there. Oh, wait. I guess it just takes time, which I don't.
Maybe delay a little.
Huh?
You went one too far.
I know.
Oh,
There. Okay. What about thyroid disease, particularly low or hypothyroidism? Symptoms develop over time and you not even know what you feel like when you were well. So they can develop over a year, year and a half, 2 years. You start to notice that you're gaining weight. You may start to notice some swelling in your legs. A lot of people start to feel that their brain isn't working completely right. They may try to diet, but they're still gaining weight. They may notice that their pulse is really slow. So those are things that you have to check out. Hyperthyroidism is a little different because I think if you were hyperthyroid, you may clue into it. You just get really, really anxious. You find that your pulse is very rapid. You're losing weight, despite the fact that you may not be eating because your appetite's gone. So those are things that also have to be checked out because hypothyroidism can also lead to death. It's called myxedema coma. And eventually it affects the brain, and you can go into a coma with it. Okay.
Maybe we can just
It's okay.
Try this.
Ah, there we go. Much better. Okay. So what about cognitive impairment and dementia? We all know that as we age, we may forget the names of something. We may forget that we left our keys in a certain room, and that can be part of normal aging. There is an entity called mild cognitive impairment that's really not necessarily part of normal aging, and it may not progress. But in the majority of cases, it can progress on to what we call Alzheimer's disease. So we do have screening for it. And in fact, the British Medical Journal came out with a terrific screening tool that can predict whether or not you'll develop it within the next 10 or 14 years. Now, I don't know if I would want to know that. I don't know if a lot of people would want to know that, but mild cognitive impairment is a little bit more than forgetting names and a little bit more than forgetting where you may have put your car keys. Your friends may start noticing it. Maybe your bridge game is off. Maybe, you're forgetting more than just words on things. And it's not really gotten into dementia yet, but it's pre-dementia process. So you would probably want to go see your primary care and get screened for that. In fact, usually at your wellness to Medicare, we all often do the screening for memory impairment. We usually do something called an MMSE, but we go a little further in our practice. We do something called the MOCA, which is the Montreal Cognitive Assessment Tool, which is a little bit deeper because a lot of people, particularly well-educated people, will score 30 out of 30 on their MMSE. But when you do the Montreal Cognitive Scale, you can really start to see areas of decline because it's just a little bit more of a difficult test. So you'll start to see maybe the short-term memory declining, math test declining. So it's probably a little bit more to do when you go for your testing. A lot of people know about the immune modulators that have come out now for Alzheimer's disease. It's called Legembi. I'm not going to say the other name for it because I cannot say the generic name for it. I would just burn it up. Legembi has been made now by Medicare Medicare says we can be giving it to our patients, very specific category for those patients that would get it. So someone with very early onset Alzheimer's disease could be a candidate. We have to do blood tests to show that they have certain amyloid in their blood tests, and we've got the blood tests now available through LabCorp. We also have to have an MRI showing amyloid content in the brain, but it's not without its problems. It can cause brain swelling. It can cause hemorrhage in the brain. So we're working on trying to see if we're going to do it at the hospital. Once it becomes available, and we'll probably announce it through the hospital that we may be starting to use it. But again, it's one of the new immune modulators that have come out, but it's not without harm. And I just tell my patients that. Common forms of disease are Alzheimer's disease, which is the most common. Then there's Alzheimer's and vascular dementia, which can be mixed together. And then there's vascular dementia, which occurs because of strokes. And then there's something called Lewy body dementia, which patients with Parkinson's have. And usually with Lewy body dementia, it starts off more with gait abnormality, and memory usually becomes later on. So very subtle differences but the treatment is basically the same.
Are you seeing an increase in the earlier onset?
We are, because we're screening for it. I think that's why we're seeing it. And I think that people are becoming more aware of memory impairment because of advertising, things on television, talking with people. So I think people are getting more and more worried that they might have something like that going on. And then with Legembi coming out, or the immune modulators, I think people want to know, do I have it? Don't I have it? And would I be able to use that drug to cure myself? But Legembi is not a cure either. So I think we're seeing more of it because I think people are coming to their physicians more because they're concerned about it. But I think we're also not seeing enough of it because I think people are still afraid to go talk to their doctors about their memory. Yes.
How do you encourage someone to do the testing? Can't just force them.
No, you can't. But what I usually will do is I'll usually tell them that, it's better to know because we can offer you some treatment. And then what the treatment actually does is it kind of slows down the progression of the disease. So that's kind of how, we tell the patients that you probably should, get diagnosed. And we usually, with the diagnosis, we get a CT scan of the brain. Sometimes it'll go on to an MRI. We get some blood tests. We usually will do the thyroid test to make sure that it's not hypothyroidism that we're seeing. And we'll get some electrolytes and a CBC, things like that. But that would be typically what we would do. And that would be encouraging them to get tested because we can offer them a treatment for it. I just have to get this perfect serve. Hold on. I'm unfortunately on call tonight. Okay. And then there's something called frontal lobe dementia, which is very difficult to treat. And that's where the patient becomes very aggressive, very angry, and they often don't respond to a lot of the medications. And that's so much harder to treat.
Do we have facilities in Wilmington to handle patients like that?
No, we don't, unfortunately.
Well, frontal lobe, but dementia,
Right.
yes.
Dementia, yes. Dementia, definitely.
Frontal lobe.
Absolutely. Frontal lobe, aggressive patients are a little bit more difficult to find placement for. There's the Dunes, Carolina Dunes.
Well, it wouldn't be residential.
Right, it wouldn't be residential, but you could have someone go there to maybe get some medication changes done. But no, it's difficult to find treatment for them, unfortunately. But I don't know if you've heard that we're getting a psychiatric residency program coming within the next year to the hospital. So I think that's probably actually going to help a lot. And hopefully we're going to get some more psychiatrists for outpatient department. And I think that will also really help. So it's the aggressive patient that really becomes the problem. But there's treatment for that too. So we often try drugs for them, but that will be usually what caregivers can't handle anymore. So when it gets to that point, they usually want the person placed. They'll usually bring them to the hospital and say, I'm not taking them back home. So that's why we want to get on top of that and try to treat them for the aggressive behavior before it gets to the point where they just can't manage them at home any longer.
Do you find it's more men aggressive than women, or equal across the
I think it's equal. I really do. I really find that it's equal. Yeah. And sometimes there's an underlying reason for that aggressive behavior. Sometimes they could be in pain. You have to be a bit of a detective. So, are they in pain? Do they have an infection somewhere? What could be going on that would make that change in them to become so aggressive? Is it depression going on? So you might want to try some different things to look for maybe what could be the cause of it.
Can you just clarify? I think I might have misunderstood. So is Lewy body always the same as Parkinson's, or is that two different?
No, they're two different things,
diagnoses?
but if a person has Parkinson's and develops dementia, it's often Lewy body dementia.
Okay, so what
Mhm.
makes Lewy body
Mhm.
dementia? Like, what makes it Lewy body? Why is it like its own category?
Yeah, because it usually starts in a different way. It usually starts with gait abnormalities and then personality changes, and then they get into the memory. And it affects kind of different areas in the brain.
Okay, so kind of how the whole thing
Mhm, right.
initiates.
Mhm.
Yeah, thank you.
Okay, how do I do that change again? We rely too much on technology. That one, okay.
Oh, wait, you're kind of zoomed out. Sorry, let's see.
Okay, there we go. Thank you. Hearing loss. Hearing loss can contribute to dementia. And I'll tell you that because if you can't hear what the person's saying, it's a sensory loss. You may be sitting in a room with a group of people, but if you're not hearing what's going on, it's like you're in your own world. And I tell my patients, get screened. Please get screened, because if you can't hear what someone's saying, how can you participate in an activity? And that's a really hard thing for people to accept, to go and get screening and to get a hearing aid. It's just like a sign of vulnerability. I see that all the time with my patients. My husband, I said, I can't believe that you won't go get your hearing tested. We're screaming at you half the time. But I think I finally convinced him to go, so let's hope he does. But it does contribute to dementia. My mother used to keep her hearing aids in a drawer. I said, boy, your clothes can hear really well. So it is a contributing cause, because you don't want to participate. You don't know what's going on. You feel isolated. You don't want to sit with someone at the table because you know it's irritating to keep saying, what did you say? What did you say? So I encourage my patients to get their hearing checked, because I think it is a contributing cause to dementia.
You might want to tell your patients to go to Costco.
Oh, I do tell them that all the time.
Okay. I've had 3 pairs. Costco was the best, least expensive I've ever had.
Yeah, no, I tell them that all the time. All the time. I say, get a Costco card, it's worth the money.
Yep.
Absolutely. Now, let's look at the skin lesions. Why should we, who's gone to a dermatologist in the last year? Good for all of you. I finally went. And don't rely on your primary care to do it. You gotta really actually, for this, you really should go to a dermatologist. So common skin lesions, seborrheic dermatosis. I tell my patients they're wisdom spots, because as you get older, you get more of them. So usually they can be everywhere, and they can also be those kind of growths you'll see too. Those are seborrheic dermatosis. Wisdom spots, everyone has them. Benign, they'll stay with you. Nothing to worry about. Now let's go on to these. This is a basal cell. It almost looks like it's a pearly lesion. And I'll sometimes see them on the eyes, you'll see them on the face. And you want to get those looked after, definitely. And then beside it is what we call a squamous cell cancer. And it usually kind of starts, again, on the upper extremities often, sometime on the ear, sometime on the face. So again, you want to be screened for that. And then these are the scary ones, melanoma. And if you look at where a melanoma often is, on the heel. Yes, yeah. Often starts on the heel. Do you often look at your heel? I don't. So, and sometimes it'll be under a fingernail. You'll notice there's a black spot underneath your fingernail. Probably not a bruise, it's probably a melanoma. So you need to really get that looked after, and they do something called the Mohs procedure for that. So if you notice, or an irregular, and if you look at that picture, you can see there's irregularity in the color of it, and it will be irregular. Some areas will be black, some areas will be brown, but there's so much irregularity to it. And as I said, it'll start right on that heel. So that's why someone's got to always look at the bottom of your feet. And if your dermatologist doesn't do it, change dermatologists. Seriously. In honor of Jimmy Buffett, Merkel cell cancer. Rare as anything, but can be deadly. Can also be cured in some people. It starts in the neurofibroma cells. Can start in the ear, can start in the eye, on the face. And then these are pre-cancer lesions. They're called actinic keratoses. And usually your doctor will give you the cream for it, but you'll see the white spots and you can flake them off almost. So those are precancerous lesions that you probably want to get looked after too. So those are some of the common skin lesions that we can see and that we want to get screened for. Who's up to date on their colon screening? Well, that's good. That's positive. That's something that I keep up with. So let's talk a little bit about colon cancer. When do we start screening? We start right now at the age of 45, but we probably should start at the age of 40 because we're starting to see so many cancers in people at around the age of 40. It's unreal how many cancers we've picked up. So we start at the age of 45. It depends if you have a family history of colon cancer, then usually it'll be 2 years before the diagnosis of the first family that had it. So if your dad had it, let's say at the age of 40, we would start screening you at around 38 or 37. Also, if you had anything like ulcerative colitis or Crohn's disease, you get screened. So usually we get screened over the age of 45, and then it's every 10 years as long as you don't have any polyps or lesions. What about other kinds of screening like Cologuard? So Cologuard is a test. You do it every 2 years, put a stool sample in and send it off, and it detects blood. The only problem with the Cologuard is you don't get visualization of the colon. So you wouldn't know if there was a polyp in there. So I think if you wanted to, you could do, colonoscopy, and then maybe if you didn't really want to go for the next one, maybe a Cologuard testing as long as you didn't have any polyps. So it's kind of up to you to decide what you want to do. I think visualization often is the best. When do you stop screening? They stop screening at the age of 80, unless you went into the hospital with a bleed. I've had patients had colonoscopies at the age of 88 if they've had a bleeding, just to see where the source might be. But usually it stops at around the age of 80 in general. What about prostate cancer screening? Now, it's a big debate on that one too. But generally in African Americans, it's over the age of 45. And in white males, it's over the age of 50. We talked about the bone marrow density over the age of 65, unless you've had a pre-fracture, it's 50 to 64. And then lung cancer screening. So if you've been a smoker and you're 55 to 77 years old and you've smoked for 30 years, you can get what we call a low-dose CT scan to screen for lung cancer.
Dr. Rubin,
Mhm.
what if you lived in a house with a smoker?
No, you wouldn't qualify. Yeah, so you have to be the smoker. Breast cancer, at what age do we start screening at? In the United States, we screen at the age of 40. When do you stop screening? That's personal. And for my patients, I have 90 years old that I still screen with because they're very active. They want to be screened. Some of them at the age of 75 don't want screening anymore. But you still,
Better method, that would be great.
I know. Yeah, I agree with you completely. But at least we want to make sure that they do breast self-examination. So, but patients are interesting. I mean, if they don't want to do it, you sometimes just really can't convince them about it. So you just advise them and tell them to at least do the breast self-screening. And when they go to see their doctor on their yearly visit or whatever, that you want to make sure that you do the breast examination. What about your immunizations? So we have flu. If you're over the age of 65 or in a high risk category, you want to get the quad flu vaccine, which is for the older or the higher risk population. Pneumonia vaccine, we're now doing the Prevnar 20, which is, they say, the only pneumonia shot you'll ever have to have. But you can't have it if you have to wait 2 years from your last pneumonia vaccine. RSV is coming out. The interesting thing with the respiratory syncytial virus is it's considered a drug. So if you don't have a drug plan with your supplement, you have to pay for it. And I think it's a pretty high sticker on it. So, but worth it, particularly if you have lung disease, asthma, COPD, definitely you should be getting it. COVID is going to be every year. I think there'll be a new COVID shot every year, and we're not calling them boosters anymore. It's kind of like the flu shot.
Is it necessary?
Yeah, I personally think it is, because there's so many different variants that are out there now. So I advise my patients to get it, but again, that's something individual that you have to decide upon.
Would you advise it if they're over 95?
Yeah, because if they get the disease, now we're seeing milder variations of it, but I have to tell you, this summer we've seen a real increase in it. And I think part of the issue for the summer has been that it's been so hot outside that people are out doing less activities outside. They're congregating more inside, and I think that's how it's getting spread more. We've had it in all of the nursing homes. Every nursing home has had it, and it kind of, oh, you got it, and then 2 weeks later, someone else has got it. So it's out there, but we're finding that not as many people have to be admitted to the hospital, which is great. And I think in part that's because we've got some immunization now, and we also built up some tolerance to it. So I think those are all positive things. But the more people that get the vaccinations, the better for all of us. Shingles vaccine is something that we should get. It's a 2-step vaccine. You get one, and within 6 months, you should get the second shot. I don't know if any of you have had shingles, but it's not very pleasant. So you can still get shingles after the vaccine, but much less of a severe dose of it. Anybody have any questions on the immunizations or the vaccines?
I do, about the RSV. There's so many studies going on now about the RSV, and I was signed up to go tomorrow to start on the study, and they called today and said that they don't have enough medication right now to start, that they'll start the 1st of October. Is this a smart thing to do a study? Because you don't know if you're getting the real thing or not?
No, I would get the real thing.
You would go ahead and
Yeah,
forget
I
the
would
study.
definitely get the real thing. Do you have a drug plan?
Oh, yes.
Then get the real thing. If you didn't have a drug plan, I mean, you may want to not do it. I prefer different prices for the RSV.
But don't you think that they're actually giving you the real thing so they'll know what your side effects are?
I don't know.
You'd have to ask the details of the
Yeah,
coordinator of the study.
I don't know. But if they're doing a really good study, they wouldn't, half would get it and half wouldn't.
What is RSV?
So it's respiratory syncytial virus, and oftentimes babies get it.
Okay.
Okay, but it's more now in the older population, and they can become very sick with it. People that smoke, people with underlying lung disease can get it. We screen for it now in the hospital, just like we screen for pneumonia. We run a panel on it. So it's important to get that vaccine if you're at high risk,
My doctor has not mentioned that to me.
because it's just coming out. So you wouldn't be able to get that vaccine yet. It's just coming out now.
And is there an age minimum on that you would, I mean, because babies can get it anybody.
Yeah, absolutely. So I think it's more the high risk category you want to look at.
Sorry.
Yes.
Well, my comment was more or less to the clinical studies. I've done a couple clinical studies and they're fairly intensive. You have to track down like the injection site. You've got to take your temperature every day. There's a lot to doing a clinical study. But I would figure out, I'd read more into it before you actually do it, if you were to do it.
Okay. Advanced care planning. How many people have their power of attorney? Well, that's pretty good. What about their will? And what about the most form?
What is that?
Oh, I'm going to show it to you. Perfect. And I didn't even set her up to do that.
Set me up.
So the most form is what you can fill out in your doctor's office. And it's basically what can go with you to the hospital. So it talks about more than just, would you want to be resuscitated or not? It goes into, would you want the full scope of treatment? Would you just want to go into the hospital to get fluids? Let's say you decide you don't want to be resuscitated, but you would want to go there to get fluids. You would want to get, treatment if you had a heart attack. You would want to get antibiotics if you had an infection. And then it talks also about artificial feeding. And I often say to my patients, if you had a stroke and you couldn't talk anymore and you couldn't eat, would you want to have a feeding tube to keep you alive? So it's talking more about that. And you can change it at any time, but at least it gives an idea and documentation of what you would want to do. And I think it helps your power of attorney, because that might be when it comes into play, to kind of look at your living will and help make those decisions. Because it's very hard for the family if you've never talked about it. It is very, very difficult. Family members will come in and say, I have no idea what they ever wanted. Like, no idea. So it's something that you can do as a gift for your family almost, to put down at least what you think you would want or not want done. Particularly if you had underlying dementia, severe heart disease, think about what you would want done to yourself. So we encourage our patients to look at that. We'll often fill it out at our first office appointment with them. And things change over time. I've had patients say, oh, my mother, when she did her advanced care planning, wanted to always be resuscitated. I said, but yeah, that was 15 years ago. Your mother now has a terminal illness. Do you really think she would want that now? So you spend time with the patients, but it's good time spent, because you don't want to do things to people that are going to be what we call futile care. Because if you've ever seen someone suffer a cardiac arrest and you see the aggressiveness that's done when we try to resuscitate them, it's not a very pretty scene. And a lot of times brain flow may be much less than what it was before. So if they have underlying dementia, they may not come back to their previous status. So again, those are really important things to discuss with your physician.
And that's a signed physician order.
Yes.
When it's all finished, it's an order, so you carry it to the hospital.
Yeah, but you have to always bring the original. So I always tell my patients, put it somewhere visible. If EMS comes to bring you to the hospital, they'll take the original form with you. So you want to have that original one done. Power of attorney is important too, so it can be enacted when you can't make your own decisions. So healthcare power of attorney, financial power of attorney are important to decide and talk about with whoever you make the decision for those people to be. And that's something that you would go to your lawyer for.
Dr. Rudick, this does not replace the DNR form.
It does.
It does, okay.
It does.
But
But
this
this-
can be revoked.
This can be revoked.
But the other one is typically not revoked?
Well,
Or
the
they don't
DNR
use it.
policy, the DNR, you can revoke that yourself.
Okay.
You just say, I don't want to be a DNR anymore.
Mhm.
This can be changed too. I mean, let's say you change your mind about it. We will review it maybe every year, every 6 months. But that counts as your DNR.
So is that like a New Hanover County form?
North
or is that-
Carolina.
It's a North Carolina state form, but that isn't like filed in our file, it's,
So if you go to the hospital, we can put it in your file in the hospital along with your advanced care directives.
okay.
Mhm. But you always have to bring the original.
Okay.
So make sure you get the original back.
That's the part that confuses me. Like, I have all that stuff from my mom, but like, yeah,
Right.
when it happens, like, what in the world do we need? I
That's
have
what you
teacher
want when it
meeting.
happens. That's what you want to take with you.
Okay,
That's it. The advanced care planning says if I'm terminally ill, I don't want this and that done. That one says, I don't want to be resuscitated. Okay?
Some people put it on their refrigerator.
Exactly. That's what I tell people to do. Or above their bed.
Because then if you call EMT,
They
say
might-
it's on the refrigerator.
Right.
They can grab it.
Exactly. So the advanced care planning is different because then there's nothing in that that says, I don't want to be resuscitated unless, I'm horribly, terribly ill. And then, but this one does. This is a DNR.
Can you just download that from a North Carolina healthcare site or?
No.
It would be.
Yeah, and there's a front and a back to it.
Right.
Your doctor should have them, although I'm very surprised sometimes when we.
They don't
consult
have
with
them.
patients,
My patients will say, I've never seen that before.
Physicians say that?
My patients will say
Oh, your
that.
patients?
like at a certain age, like, so like I've never been shown that before, but I mean, I'm 46, so like. don't
I
know,
wouldn't
but,
expect you probably to be showing that
Like-
unless you had an illness
like, no, yeah,
that might lead
sure.
to that happening in a few years
So
or
you
whatever.
think, like at 72, someone when they went to their doctor.
Would get that form.
physical would have-
At least we would discuss it.
Okay.
But
Yeah.
you can ask for it, and you can go online and look at it and talk to your
Right.
loved one about it.
But you have to have the
We
pink
need to
one.
Discuss this with the doctor.
Right.
Because I need to find out what you want.
How long has this been in play? Because I've never heard.
Years.
Years, yeah.
Years. Yeah. It's been in place for a long time.
Marsha Fretwell used to say, she got like all over here, death is coming, isn't it? She said, fill it out, tell them what you want to happen.
I mean, it is true. It's your body and it's your life and it helps your family.
It seems like it would be good practice for the doctors to do it at the Medicare wellness.
Exactly.
Yeah, that would be a good.
That would make sense.
Yeah,
Instead of when they're on their dying bed and saying, excuse me,
yeah.
just want to ask you this question. Yeah, you're exactly right. So I always tell my patients that I say, the best time to do this form is when you're well. That's when you can make clear decisions and not when we're in a crisis. Because when we're in a crisis, we make the wrong decisions because we feel guilty, we feel bad, and all those emotions come swarming in. So, do you have a question?
Yeah, so my cousin has muscular dystrophy,
Mhm.
and he had requested to do a DNR,
Mhm.
but his mother, who is in charge of him,
Mhm.
said no.
So does your cousin have capacity to make his own decisions?
He does, but she has warranted that he does not, because she still wants to be in charge of everything.
So what I would do is he probably needs to be evaluated for capacity. And once he is determined that he has capacity, he can,
By a physician.
right by a physician, he can definitely do that. Mhm. Yeah.
But the opposite, it also happens because we have families that said, well, I'm the power of attorney, I make the decision, and I want everything from mom. Well.
So it
she hasn't
depends.
been deemed incompetent.
Right, exactly. So you can have a power of attorney, but it's not enacted until you lack capacity. And that's why I tell my patients, I said, don't be afraid, because nobody can make your decisions for you until someone says you can't make your own decisions. Because a lot of people think, oh my God, if I give them power of attorney, they're taking away all my rights. And they're not. It doesn't happen. It happens when you're deemed lacking capacity.
What does that mean? What is that?
That means you have dementia, you can't really make clear decisions, you, usually it's done by, I mean, we do it all the time in the
Yeah.
office.
Because the physician is the one that.
Right. Physician has to do that, and usually it may require 2 physicians, but yeah.
I was gonna say, I feel like competency is like a legal.
Yeah,
determination.
so that's why we say lacking capacity, not that they're incompetent, that's a legal decision.
Okay.
So we say lack capacity, and then, so that's what I would do with your cousin. Okay, so what are the important things that you can do for yourself? We got diet, exercise, sleep, and socialization, and we'll go into each one of them. Everyone loves a diet. Weight sneaks up on you. Anyway, so I like the MIND diet, and I tell my patients with memory impairment that that's what they should be on, although a recent study came out which kind of leaves it open in the air as to whether it helps or not with dementia, but it does help with feeling good. It avoids a lot of the red meats. It's a combination of the Mediterranean diet and the DASH diet, which is low salt diet. Let's just look at it. So 10 food groups you should eat from and 5 to limit. So daily, at least 3 servings of whole grains, fruits, and vegetables, 1 to 2 servings of beans, poultry, fish each week. Daily snacks, nuts and berries. Limit butter, cheese, red meat, fried foods, sweets, pastries, and alcohol. You can download it online, but it's really a good diet. It's a very healthy diet. All of us really should be on that kind of a diet. We should be eating less of the red meats and more fish. And what about exercise? Well, look at Joan. She was on a mission at age 70 that radically changed her life. So she decided that she wanted to get her weight up, probably went on the MIND diet, and started to exercise and really slim down. And what about the benefit? Who exercises in here? How many days a week do you exercise? Yeah, I do 5 days a week too. I found that it's just helps me immensely with my stress levels, with my thought processes. It improves my mood. My stress level goes down for at least the time period I'm exercising. It improves balance and bones. Let's talk about the bone density. Let's talk about reversal on your bone density. I reversed my bone density. So I had some osteoporosis, and I thought, I'm not, aside from vitamin D, I do not want to go on the bisphosphonates because of problems with your jaw and a few other things. I thought I'm going to try it for 2 years. Exercise, weights, weight-bearing exercises, walking, running, and my bone density reversed to osteopenia. So it can be done. It's amazing what you can do when you put your mind to something. But yes, definitely exercise helps reverse osteoporosis, vitamin D, weight-bearing exercises. It also improves your sleep, lowers your blood sugar, helps with your brain health, and your cardiovascular benefits are so well known. So everyone should try to do exercise. We say 150 minutes of exercise in a week. Now there's patients that can't do that. And then we can modify that for them, but at least they should try to get moving. Many studies have suggested that certain areas of the brain really, really improve with exercise more than people that don't exercise. So that's even more exciting because you're actually improving yourself mentally as well. And And it's just fascinating what it can do for people. So I always tell my patients, start low and increase, or my caregivers, even if you can only do 10 minutes a day, that's a start. And it's better than nothing. So start with slow walking, go out for a walk, and slowly increase the time with it. Do what you like to do, or do what you can do that's the least adverse for you. Let's put it that way.
least.
Exactly. Swimming, dance. A lot of my patients love dancing. And that's great exercise too. It's a good aerobic exercise. There's a lot of classes at the senior center or gym, all have the added benefit of socialization, strength training. With Medicare Advantage programs, they have the gym that you can go to. So that's something good as well. And what about sleep? Sleep is so, so important, because if you don't get sleep, you get irritated, you're not thinking clearly, you're not making the right decisions. Sleep keeps your brain healthy, it helps with your immunity, and it lets the body repair itself. That's probably the most important thing. It really does let the body repair itself. If you don't get enough sleep, you put extra stress on your body, greater increase of disease, you're more likely to start eating more, you can have a stroke, blood pressure can go up, and you can have depression or have an injury. So those are all of the benefits of sleeping.
When you say sleep,
Mhm.
are you talking about uninterrupted sleep, or are you talking about going to sleep a couple hours, getting up, go to the bathroom, going back to sleep, getting up, go to the bathroom?
Whatever works. So if you find that you can, uninterrupted would be better, but if you have to get up and go to the bathroom, but you can fall asleep right away, again, that's okay too. A lot of people.
Number you need.
Everyone's different. Some people need 6 hours, some people need 8, some people can do 5 hours, some people need more. So it depends on that person. But it's whatever's going to make you feel better in the morning when you wake up. And let's talk about socialization. Doesn't it feel good when you get together with your friends in a group? You can talk and you can mingle. It helps with your mood. It helps with your memory. It reduces stress, isolation. So all kinds of really good things with socialization. Keeps your brain active. There's several areas to go. I always kind of recommend senior resource centers, the Elder House Day program for some of our patients with caregivers, church activities, volunteer opportunities, local gym, community classes, online education. There's so many resources that we have available for us. And we just have to make that first step. And the first step's always the hardest for people, because they feel that, you know, they don't know anybody. Nobody's going to sit with them. And, you know, once they go, it's great. They feel so good once they get going. So one of the things that we do have to talk about, though, is caregivers. And what's the first rule of caregiving? Do you know what that is? Those are the oxygen masks coming down a plane. And what do they tell you?
Take care of yourself first.
Exactly. So first rule of caregiving, take care of yourself first. This is the only way you're going to help others. So you got to look after yourself. You have to recognize the signs of burnout, draw support on things that are in place, and take care of yourself. And you have to recognize the signs of burnout in yourself. These are interesting. These are scary statistics. If you're a caregiver for a spouse between the ages of 66 and 96 and are experiencing mental or emotional strain, risk of dying is 63% higher than that of people of your age. So caregiving does put a big stress on people. And if you don't know how to care for yourself, you will be in that group. And we don't want that. It's a big job to care for someone. What are the signs of caregiver burnout? Crying a lot. You're exhausted most of the time. You don't want to go out with people. You don't want to go for lunch with people. You're resentful, short-tempered. Your thought process is kind of all over the place. You may develop a dependence on alcohol or stimulants. You lose interest in work, hobbies, and relationships. So when you start to feel like that, there's a lot of resources that are available. You can consult with a professional counselor. You can come to support groups specifically designed for caregivers. You can ask for help. And sometimes you think you can only ask for help for your loved ones, but you can't. You have to ask for help for yourself as well. Regular exercise, good nutrition, consult with your doctor, establish a routine that involves doing something you like to do. If you like to journal, do meditation, talking with others, but you have to do something for yourself. Otherwise, you'll be one of those statistics. And recognize if you're unable to provide a caregiver or a person that you love the needs that they have, and make a plan. For example, you can keep a caregiver at home or a person that you care for at home for as long as possible. If you start to find yourself that you're getting burned out, you should start to think, I may need some help to keep them here. Don't wait for a crisis to happen, because then they end up in the hospital, and then they'll end up in an institution because you are so burnt out that you can no longer deal with that person anymore. So what you want to know is there a family, community support group? You aren't the only one that can take care of a loved one. Some people think, I'm the only one that I can do this. Nobody else can do it as good as I can do it.
Not a question, but just kind of a comment.
Mhm.
Too often in the funeral business, we see where the caregiver actually passes first.
Absolutely. That is so true. That is so very true. And then what happens to the person that they were looking after? That's exactly right. And oftentimes they think they're the only ones. And you know what? They aren't, because you just have to accept someone may do it a little differently, but they're still going to look after that person, and maybe not the same way you will, but they will provide some care. So you just have to take kind of it in a different way. When you go to see the doctor, you should, or your attorney or your financial planner, let them know what you want to talk about, because you want to have the time. Okay, so you don't want it to be a 10-minute or a 15-minute visit. You kind of want to say, this is going to be an extended visit. We want to talk about a lot of things, and bring someone with you, because you want someone else to hear what's being said. Set goals. If the first goal or solution doesn't work, you try another one. If that doesn't work, you try another one. And ask for help. I mean, maybe you can ask a neighbor to go grocery shopping for you. Maybe you can get someone to spend an hour so you can go out and walk. So ask for help. A lot of support for seniors. We went through those. We have the Senior Resource Center, Elder House, respite care at the nursing facilities or assisted living, Project Care. So in conclusion, we're all living longer, but we want to live well. Remember what Mickey Mantle said? If I knew I was going to live this long, I would have looked after myself better. Be aware of all of those common conditions that can hurt you. Practice screening. Put in good habits in place for disease prevention and help you care for your loved one. As a caregiver, take care of yourself first. Remember those oxygen masks coming down. Learn and use stress reduction techniques, meditation, prayer, yoga, Tai Chi. Attend to your own healthcare needs. Those are so important. Get rest and nutrition. Exercise regularly, even if it's only 10 minutes at a time. 10 minutes in the morning, 10 minutes in the afternoon, 10 minutes at night. That's 30 minutes a day. Take time off and don't feel guilty. Participate in pleasant, nurturing activities such as reading a book, having a bath. Seek and accept the help of others, and that's so hard for some people. Get some counseling if you need it. Identify your feelings and acknowledge them. You have a right to all of them. This is a hard job. Change the negative ways you see solutions or situations. Set some goals for yourself. And you have to do that because it is the toughest job I think we ever. And what if you don't like the person you're looking after? I mean, seriously. What if there's so much resentment? And I've had families that say they never really liked them. And here they are now having to look after them. And there is so much resentment and guilt. That's a harder one to deal with. We have some handouts.
They're over here on the
They're over
table.
there and open to any questions that you have. But you do have to look after yourself, or you can't look after that person.
So how do you know, like, when this is for my mom, but like, what is the signs of cognitive impairment? When you're like, this is more than I just forgot my keys. Like, when we're hearing the same story 7 times.
Right.
I'm like,
Mhm.
that's new for us.
When
So-
you go to their home and you look in the refrigerator
Mhm,
and you see food that's old,
mhm.
okay? Weight loss is a big one. Not keeping themselves clean, so you start to notice a smell. Normally meticulous person, their house is now not kept up. Those are some of the signs. Not returning phone calls, not socializing with friends, all of a sudden stopping their activities. Those are a lot of the signs that things aren't right.
Okay.
And that's what you should be looking for.
Okay.
Particularly, you start to look in the refrigerator and you see this food that's been there for weeks. Nothing's been cleaned out. Those are what you should be looking
Or
for.
you find toilet paper in the refrigerator,
There you go.
food in the bathroom, or
And you find the butter in the bathroom.
If they're not taking their medicine.
Oh, medicines too. They're not taking their medicines. Absolutely. They haven't filled their prescriptions for months. Mhm. Don't know what medications they're on, don't care. Mhm. Don't get dressed in the morning anymore. Sleeping much more during the day. All of those things are kind of indications that something is just way wrong here. Yeah, that's not my mom or my dad. Mhm.
Okay.
And I know you have a really good session on scams.
Yeah,
Yeah, that's another one where they get taken in. Mhm.
yeah, that one's scary.
Dr. Rudy, what are your feelings on vitamins to help with cognition, like vitamin B12, folic acid?
So I always check vitamin B12 levels. We always check folic acid. We check vitamin D. If there's deficiencies in any of them, we start the patients on them. So that's kind of where I feel it is. If they're eating a good diet, I'm not sure that they need those vitamins if they're not deficient in it. So that's kind of my feeling about it.
Yeah, I'm just curious.
Mhm.
What about over-the-counter Prevalent or?
Well, I'm not even going to go there.
Okay, there we go.
There we go. That's the answer to that one. And that's expensive.
Is it?
Yeah,
I've always known it to be kind of a hope.
it is, but it's expensive.
Dr. Schmeck, do you remember Dr. Schmeckel?
Yeah.
Yeah, I asked him once, what can I do to help prevent myself from a cognitive decline? And he said, well, there's no data or research, but if it were me, I would take vitamin B12, folic acid, and vitamin D3.
So I'll tell you what I would do. I would eat properly. I would exercise my body and my brain, keep myself socialized. Those are things that I would do.
And I think the whole hearing aid thing is real important too, because.
Oh my gosh, absolutely.
Yeah.
You've got to hear. And you got to get a hearing aid. And you should go to Costco for it.
Or the VA if you're a veteran.
Or the VA if you're a veteran. There you go. Absolutely. Now I take vitamin D3. I've done that since COVID came out.
Yeah, me too.
Yeah.
What is a good level for D?
As far as
It's changed.
so I take 5,000 a day.
And what are you looking for your level?
You want your level to be around 40 to 50. When you check it out, so you want it above 30, definitely. And remember that as you get older too, we don't absorb as much of the sun because of melanocytes in our skin. So you have to have a higher level. So I take 5,000 a day. One little pill, get it at Costco.
We love Costco. Make sure it's combined with vitamin K, because the K helps absorb the D into the bone.
So that's what I would do. Just go to Costco, 5,000 units a day, get it checked out.
Did you say B3 to 5,000?
No, vitamin D. D3, yeah.
Yeah, didn't they, I was talking to a hospitalist down in Brunswick, and he said they saw a lot of COVID patients that were low in vitamin D3. Was there a correlation there?
I don't know if there's, sometimes people think there's a correlation with everything. They see one study one day, one study the next. But I've taken it since COVID. Like you would?
D helps with immunity.
It helps with immunity, and I haven't had COVID yet.
Yeah.
Wow.
Yeah.
And is
I've been
that
around all kinds of, well, with what the job I do, I'm around everybody.
Yeah.
And I can't believe I never got it. Wow.
do you recommend that now regardless of age?
Yeah, I do. I think it's a good level to do.
So like my 25-year-old daughter.
Yeah.
Good for her.
Yeah. Absolutely. Anything else? Now's your chance.
And she's always on the move.
Oh.
She definitely stays young and active.
So, yeah, that's what I would do. I mean, you got to exercise the brain, you got to exercise the mind, you got to eat right.
Yeah, but you
Sleep.
definitely have to stay young and active. You personally.
Oh, I stay out.
Yes.
Show me some of your exercises.
I do kickboxing now.
Oh.
Yeah, I love it. I've been doing it now for 3 years.
Where do you go?
The 9 rounds.
Okay, yeah.
Yeah.
Fun.
I have a lot of fun with it, yeah.
And you go early, don't you?
I go at 5 in the morning.
Oh, my God.
Anyway,
Early bird.
early birds.
Well, thank you. I'm Ruth Finch, and I'm going to be the one wrapping up for this evening. So thank you, Dr. Rudy, for all your helpful tips for all of us. Did a great job as usual, and thank you for our sponsor this evening, Wilmington Funeral and Cremation. Thank you for hosting the event for us, and then thank you for everyone here that attended in person and via the computer here online watching us. Thank you for your input. And then we have feedback forms for everyone that's in person at the tables. If you'll kindly fill those out for us and tell us how to improve our programs. If there's any particular topics that you'd like to hear about, we'd love to have those. And then our next program, we have a full schedule on each table. Our next program will be here at this site on October the 10th. And it's Losing My Independence, Driving and Aging, which is always a fun topic with your parents. So be sure to join us for that one. And thank you again for attending this evening.
Thanks for having me.
Glad you said what you said about hearing loss and dementia.
Mhm.
I've told several of my friends that, and they said, they look at
Absolutely.
me like you're crazy. I said, no,
No.
you can't hear it.
Exactly.
Yeah.
That's exactly right.
But at Costco, I've got the best hearing aids for the